Okay, well, good evening, everybody. Thank you for coming to another monthly teaching. This evening, I've got Raghu, who is one of my colleagues. He's also the president-elect coming into the British Society of Interventional Radiology, and I'm very happy to have him here this evening. He's going to give us some teaching regarding carotid stenting. We all have to do a bit of carotid stenting here for treatment in stroke, and I'm very happy to have Raghu here to give us some insight into that. So I'm going, with no further ado, I'm going to hand over to Raghu, who will teach us a bit more about carotid stenting.
Thank you, Aubrey. It's actually a privilege and an honor to do this for the team, and I mean it because of one reason. Because I have a bugbear with carotid stenting. I think carotid stenting has a second place to carotid endarterectomy, and we'll discuss why. And that is because there were some studies that were performed during the early part of 90s where, randomization is your key to finding an answer in any medical device technology in today's world. So what they did was they randomized patients who came in with TIA/stroke, with carotid disease, to carotid endarterectomy and carotid stenting. And the problem with any of these randomizations are there were a lot of people. There were interventional radiologists, probably interventional neuroradiologists. At that time, probably it was one group. Vascular surgeons and Uncle Tom Cobley. Hopefully none of you are French. There were a lot of French people, etc. And finally, carotid endarterectomy did better than carotid stenting, which I believe is not a great outcome because technology has grown up. We've got better. I don't think our complication rates are that high. And if you have a major stroke, you can treat it. So I think that study has to be reperformed. I think the dials have to shift. And that's why I said it's a privilege to talk to you all, because you're the younger generation that's going to come up and say, look, we need a new trial. We need to prove that carotid stenting is far better, equal to or far better than carotid endarterectomy. With that in mind, I'm going to start off. I did call out for Ahmed and Aaron, but I didn't get any response. So let's see if this will give us a response. What I'm going to start off is I'm going to start off by showing you this case. Can you see the screen, Aubrey?
At the moment, it's just white screen at the moment, Raghu.
You can't see this particular screen, no?
Is sort of mid-shift between two slides. It's
no, hang on.
Yeah, now that's it. It's there.
You can which one can you see?
Patient selection, but it's no. Just
let me just close these, and then I think let me share again, and then look at this one. Okay, can you see the screen now? Vascular IR, right-sided transitory upper limb hemiparesis. Yeah. Okay. Yes. What I am going to do is like this and move it up. Now, the trainees who are on the call, I want you to screen this on your phone. I'll try doing it myself. I want you to stop me if you can't understand something. If you want to discuss something else, please feel free to stop me. Once you screened it, you can skip registering to this website. But what I want to know is I want to take you to the next slide. It's a 72-year-old woman who's a heavy smoker, presents with a history of ischemic heart disease, and she has previous history of transitory right-sided upper limb TIA, recurrent TIA within the last 4 weeks, and the duplex ultrasound has demonstrated a severe, greater than 70% stenosis of the left internal carotid artery, has previous history of neck radiation. So what is the best treatment option? So I've given you 4 treatment options. I want you to vote. And I want to check what people are saying. Carotid stent placement, is that the best treatment option? Yeah. Anybody taking anything else? No. So that's what you think is the best treatment option, and I completely agree with you. And why is it, even though I started off by saying that carotid endarterectomy is better, there are 2 things here, isn't it? One is the patient has a lot of comorbidities, and the second one is the previous history of neck radiation. Okay, that's why you want to do a carotid stent. Now, if you look at the next slide, which of the following statements is true regarding the procedure of carotid stenting? What I'm going to do is I'm going to activate the next question. Which of the following statements is true regarding carotid stenting? The carotid stent is sized to the ipsilateral internal carotid artery or ipsilateral common carotid artery. The carotid stent is sized to the contralateral carotid bulb, or it comes in a standard size. Yeah. So is everybody voting for the carotid stent is sized to ipsilateral internal carotid artery? Is that 100% of the votes? Anybody has any difference of opinion? Okay, here you go. I think that's a wrong answer. Any other thoughts? Any other thoughts? No other thoughts? Okay, let me take you back to the slide. The carotid stent is actually sized to the ipsilateral common carotid artery, not to the internal carotid artery. Now, this is the first learning point. Now, if you look at this particular slide, the third slide, which has a stent in place, you will see that it is broader at the bottom and it is shorter in the top. So obviously the stent is sized to the ipsilateral common carotid. If it was not, it would have been hanging in midair. Okay. If anybody has any doubts, feel free to ask me. Now, so that was a wrong answer. Carotid stent is sized to ipsilateral internal carotid. Instead, the right answer was ipsilateral common carotid artery. Okay, next question is spasm is a known complication of carotid stenting. How do you manage severe spasm? The patient complained of pain in the neck region. So the options that you have, you can see that there is spasm just above the stent. So the options you have are IV anticholinergics, balloon angioplasty, intravenous heparin infusion, intraarterial nitroglycerine. Do you know what I would do? I would just wait for a few minutes. Most often, because you've just now removed the device from place, most often it's the device that you put in to trap the clots, or the filter device, that causes the spasm and they move up and down. Okay, which is fine. So if the spasm doesn't go, the answer is right. Intraarterial nitroglycerine is what you would give. Final question. Routine duplex follow-up shows an increased velocities within the stent at 6 months. The patient was asymptomatic. What would be the best management strategy? What would it include? In-stent angioplasty, increase antiplatelet dose and anticoagulation, keep a close follow-up of symptoms and duplex, intraarterial nitroglycerine treatment. What is the best management strategy if after 6 months you see, right? So you've said, people have said increase in antiplatelet dose and anticoagulation. I think that is a very important point that you're making, and I would agree with it. The one thing is you don't treat an ultrasound-guided stenosis. You treat if there are symptoms. And what you're trying to prevent here is symptomatology. Okay? I would take your point on that. Let's go to the next case. What I'm going to do is I'm going to shut this down, and Aubrey is going to help me to see whether you can see the next case. Let me share, go to the next window, that one, and where is that case? Here. Right, Aubrey, can you see this?
Yes, I can see the slide. Yeah,
Vascular IR, left-sided hemiplegia. Okay, perfect, perfect. Okay, that's the barcode again for people who are interested. 58-year-old man presents with a past history of hypertension and smoking, has a violent bout of coughing after waking up from the night sleep. He got up in the morning. It's followed by weakness and inability to move, left upper and lower limb with speech disturbance. So what is the least likely cause of this patient's symptoms? So obviously he's had a stroke. What is the most least likely cause of it? And the causes that are given, yeah, perfect. Right vertebral artery plaque is definitely the least likely cause of it. So let's move on to the next slide and see this. So I hope you can see the image as well. I can see Aubrey's face at every, well, let me down this. Okay, so so patient underwent angiography with a view to treatment, and what you found here was thrombolysis. So what is the most appropriate management option that you see? Obviously, you can see that there's some clot there. There's something here. Thrombolysis and dual antiplatelet, mechanical thrombectomy and dual antiplatelet. Let me activate the screen for you. So thrombolysis, dual antiplatelet, mechanical thrombectomy, dual antiplatelet, mechanical thrombectomy, covered stent, mechanical thrombectomy, and surgical repair. So essentially what you have noticed is that there is an aneurysm there. What happened was he all the time had an aneurysm. He went into a violent bout of coughing, developed some thrombus, and then moved the thrombus up. So you are right by thinking mechanical thrombectomy and covered stent. So a covered stent was inserted after mechanical thrombectomy. What should be the post-procedure medication include? Let's go to the next slide, and I will activate that. So the options are, you've done a covered stent, you've done a thrombectomy, warfarin or apixaban, aspirin, clopidogrel, no medications, naftidofural. What would you choose? Why not anticoagulation? Obviously has had a recent stroke. What is the risk with covered stents? Most covered stents tend to thrombose quite quickly. So unlike an uncovered stent, I would suggest that you do aspirin and clopidogrel for a much longer time, in fact, for life, in comparison to a covered stent. Okay, now let's go to the next slide in this guy. The least,
Raghu.
the patients, yeah.
Sorry, Raghu, may I just ask a quick question on behalf of one of the trainees? They just asked what covered stent would you use and are usually available in that clinical scenario?
Okay, I will park that question and I will answer that question. Let's go to the final one. The patient's back to work and has no deficit. The least appropriate next steps in the management is needs no follow-up, duplex follow-up, rule out connective tissue disorder, look for Eagles syndrome. Let's answer this question and then we'll go back to this one. So needs no follow-up is one answer. Is that the only answer? No other answers? Okay. I will stop there. I will stop presenting and I'll answer that question. Okay, this patient had Eagle syndrome. So he went into violent bout of coughing, had a prominent, what is that thing, Aubrey? I'm having a thought block. With
Styloid process.
Yeah, this prominent styloid process too late in the day, and violent bout of coughing, and that was causing his aneurysm. Now you asked me what covered stent. Okay, covered stents are of two kinds: balloon expandable and self-expandable. Obviously, both for carotid stenting with respect to the uncovered or the covered has to be a self-expanding stent. And the reason it has to be a self-expanding stent is because it's an open area, and if somebody pokes at it, that stent shouldn't collapse on itself. So the covered stent has to be a self-expanding stent. What are the self-expanding stents that are available? There is a barred covered stent, self-expanding, that's available, and there is a Gore wire-bound stent that is available. In this case, we used a self-expanding barred covered stent. Okay. So as long as you know that you can use any self-expanding covered stent and not a balloon expandable covered stent, which is the common ones that are available in the department, you're safe. Any questions on that before I move on? If there are no questions, I'm going to move on to another presentation, which hopefully I will be able to find. Okay, can you see this? Patient selection and planning.
Not at the moment, Raghu. It's still on the last question from the previous study.
It's not on
previous presentation.
It's not on the.
It's on the last question, looking for Eagle syndrome. It's that question.
Okay, let me close that. Probably doesn't like it. Just give me a second. Now? No?
Not yet. Not yet.
Okay, let's try this again. Now?
Yes, that's up.
Perfect. Good. Right. If there are any questions, shout out. Just switch your microphone on and ask me, or go ahead and text Aubrey. Okay, so we have three scenarios when it comes to carotid stenting. 74 male presents with a 48-hour history of TIA. This is a typical finding. Doppler shows a 70% stenosis of right internal carotid artery. So this is a situation of a symptomatic, significant carotid stenosis. So this is clinical scenario 1. Clinical scenario 2 is something that you people commonly see. 84 female presents with acute onset left hemiplegia of 2 hours duration. CT shows a significant stenosis of right internal carotid artery. So here, there is a carotid disease and an evolving stroke. So it's an acute symptomatic carotid stenosis with an ongoing stroke. That's scenario number 2. Scenario number 3 is 69 male presented to hospital for a routine checkup, known diabetic hypertensive, and a routine Doppler found an 80% left carotid stenosis with a calcific plaque. This is an asymptomatic but significant carotid stenosis. What do we do with these patients? So 3 scenarios is what you commonly encounter. Okay, symptomatic carotid disease, all of you know, TIAs, crescendo TIAs, stroke or stroke in evolution. Asymptomatic carotid disease, you know, you're scanning the patient for something else and you find it. What are the interventions available? I told you that the carotid stenosis trialist collaboration suggested that is carotid endarterectomy and carotid artery stenting. So, and I also told you how from the studies, carotid endarterectomy is probably far superior. And I finally said, look, you guys have to work towards saying that carotid stents are pretty safe. And finally, timing. In all those three situations, when do you actually intervene? So what's the rationale for all the three situations? So in the one which had a symptomatic TIA, the rationale is you preventing further stroke and say that you want an urgent intervention. The second one, ongoing stroke with carotid disease, you're trying to reverse, for the sake of a better term. You want to do an emergency intervention, open the carotid, take the clot out. The third one is asymptomatic stenosis. And the question is the current risk of intervention in asymptomatic stenosis more or less than the stroke risk if you left that alone? So those are the three questions. Let's try and answer the first question. Now, when you look at time to intervention after a minor stroke or TIA, you can see in the first 14 days, there is a huge upswing of a possibility of a stroke. But as time goes along, that curve plateaus out. So if you want, from an American point of view, if you say, I want bang for buck, you want to treat it in that window of 14 days. So various evidences, you can go read those evidences, but the conclusion is very early surgery, that's within 48 hours, is not a great idea because of reperfusion hemorrhage. But surgery between day 3 and day 14 is safe and should remain the target for treatment. So somebody coming with a TIA/stroke with a carotid disease should be treated between day 3 to day 14 to prevent further stroke, which is increased at risk in those days and then plateaus off over time. So if somebody comes to you 3 months down the line, then probably there is no point. The risks and benefits are kind of equal. So what do we need from imaging? You guys are experts. Is it a stroke? You're going to say yay or nay. What about carotid artery disease? So scan from the aortic arch to the MCA. What's the degree of stenosis? I use the NASCET criteria. So if you look at it, the NASCET criteria is B minus A divided by B into 100. Now, don't try and do the mathematics. Go to your phones, just say NASCET calculator. So essentially, you have diameter of the normal internal carotid, diameter at the level of maximum disease, that is B and A, input it into your NASCET calculator that's available freely, you'll get the diagnosis. Now, for example, if I say that A is 6 millimeter, B is 6 millimeters, A is 3 millimeters, it's 50%. So B minus A would be 3 divided by B is 6, that's 0.5 into 100 is 50%. Okay, so apart from finding out the percentage stenosis, you also want to look at the morphology of the plaque. Is it a ulcerated plaque? You want to look at the level of the bifurcation, because if the bifurcation is tucked under the mandible, then surgery is difficult. Then you want to look at tortuosity. If it's a very tortuous carotid, then carotid stenting may be difficult. So those are the things that you want to get from imaging. Okay. Duplex ultrasound is the mainstay when they come with TIA/stroke. It may overestimate the degree of stenosis, but that is what is used all along. Computed tomography is being more and more used, and you need to remember that if you have a big chunk of calcium, you might overestimate stenosis. MRI, once again, is used rarely, and because of the flow dynamics, you might overestimate stenosis. Let's look at the first scenario. 74 male presents with symptomatic significant carotid stenosis. Now, if you look at this, the peak systolic velocity of the normal, which is on the left, is peak systolic is 60 odd, end diastolic is 20 odd. But look at the chap with the 70% stenosis. Peak systolic is 597 odd, end diastolic is 223 odd. So when you're looking at greater than 70%, ICA peak systolic velocities are high, more than 2 meters. And what we use is a St. Mary's ratio. That is a ratio of the peak systolic velocity versus the end diastolic velocity. Most of them are more than 15 and that is 70% stenosis. So those are the calculations that I used when it comes to duplex. Here's the picture. You can see the stenosis there at that point, and then that is a shunt being placed so that the carotid circulation is maintained, and then that is the shunt being placed, and finally you can see that's the plaque, and the plaque nicely removed and everything closed up. That's your carotid endarterectomy. Scenario number 2, we spoke about the patient who's having an ongoing stroke, this lady. So I won't take you through the images, you're experts at that. I don't want to look at that, but look at the carotid stent. So here we are. What we've done is we've placed a filter. We can discuss this in the presence of stroke. Should you have a filter? Should you not have a filter? That's something that we can discuss. That's the filter in place. That's the pre-dilatation. That's the stent going up, and that's the stent deployed. Okay, and after the stent deployed, the clot retrieved. Final one is a 69 male, where I said you found a calcific plaque, which was 80% stenosis. What do you do with it? Now, there was this more than 6,000 patients put through this trial called the asymptomatic carotid trial. We were a part of that trial. And what was looked at is procedural death or any fatality or disabling stroke. If you look at blue lines is the carotid artery stent, red lines is the carotid endarterectomy. They're more or less similar. But when you look at procedural death or any stroke, not major stroke, minor stroke, you notice that the carotid artery stent, the blue lines are doing worse off than the red lines. So minor strokes, some kind of cognitive impairment, we have to take care as a group to try and reduce that with filters and other situations. So what is my kit? What do I do? 6 to 8 French access sheath in the common femoral, 6 French long sheath, or an 8 French guiding catheter like the Fabuki, which you use for your clot retrieval. Either of them you can use. Try and use a protection filter wire or an embo shield, especially if you're doing de novo stents. As you saw in the asymptomatic trial, you don't want to have that situation. Pre-dilate if needed, all the time with a 3 mm balloon. Size the stent to the common carotid, wall stent, Acculink, road saver. There are many types of stents. Post dilate always with 5 millimeters. Use two medical agents. One is 5,000 units of heparin, and use 1.2 of atropine in order to counter any bradycardia that you may get when you dilate the carotid. So that is my kit. Okay, so what we do is we put 6 French access in the groin, give 5,000 units of heparin straight off. You may do a pigtail angiography if you don't have a view of the arch. And then what we try and do is get a trace of the carotid and get into the external carotid artery and put a short tip 260 amplats into the external carotid to exchange for a long sheath or exchange for your guiding catheter or whatever you're going to use. Once you do that, do a trace subtract and cross the lesion with a filter device. Okay, that is a filter device. What it has, and we'll look at this a bit more carefully, what it has is this filter segment. It has a wire on the top, and then there is a mark here to which point the filter comes down. So your stent has to be above that mark, and we will see how that is. So here are 3 filter devices. We tend to use the Abbott filter device or the Boston Scientific filter wire. I don't have any experience on the AngioGuard device. We don't have the Gore. We tend the Abbott one. We tend to use the NAV6 We don't have the spider effects. So essentially, the commonest thing that is used across the country is the Boston Scientific filter wire or the NAV6 from Abbott Vascular. Now let's look at this a bit more closely. So the Boston Scientific filter wire, it has this filter like this, and it has a kind of a nitinol ring that expands and sits within the internal carotid artery. Okay, whereas the Abbott filter has this kind of a basket that sits, it's not just an nitinol ring at one end, it has two connecting bits on either side. The key thing to remember is the tip of the filter wire, not the front end of the tip. That will be quite high. This tip of the filter wire should be well above the stenosis. And the reason for that is if this gets caught in your stent, you will not be able to retrieve it. So the top, you need to know where it is, but more importantly, you need to know where the bottom of that filter wire is. And I'll show you a couple of animations. So once you put the filter wire through, what you've done is you got the sheath in, you took a trace, and then you put your filter wire through and deployed it. Once you've done that, what you do is you give 1.2 milligrams of atropine, you size the stent to the CCA unless it's tapered, and then you post dilate with a 5 millimeter balloon, whatever the size of the stenosis is, and then you get a really good result like that. Okay? Take care. Stents can jump. Look at this. The stent wants to go up. Look at that. That wants to jump. So his stenosis is here, and you have quite a lot of stent in the internal, and unless you have a back pressure, the stent tends to jump up. So be careful. The stent will finally find its place higher than where you think it will be. Okay, tackling carotid occlusions. Now, if you have a carotid occlusion in the presence of a stroke, remember that it might be quite hard to get through. So that's the occlusion. And what we tend to use in our unit is to use a Synchro 14 wire with a VIA21 or a VIA27 backing it. Okay. Now I want you to see the middle screen. Can you see how the whole thing is concertining itself? It's so, look at that. It's quite hard to push through. You see that again, and then once you push through, here's your weir trying to flip past. So these lesions can be quite tough. So remember to back yourself up with a catheter in order to get past, otherwise you won't be able to get past the occlusion. And then of course we take it. Now pay attention to access. Sometimes access can be quite difficult, like in this case, very difficult access, very small diseased radial and brachial vessels. So look at what we did in this case. So we came from above, snared the wire so that you can take your sheath up, kept that snared wire in place, and used it as a kind of a support in order to take our guiding catheter up. And that is very important in order to get to that place and stent it. Of course, you can, if the brachial or radial is big enough, you can use that approach to come up, especially on the right side, and perform your stent from brachial or radial approach. Pay attention to iatrogenic injuries to the carotid. This was a patient with an iatrogenic injury and had a stroke. And what they did not tell us was that they had put in a tie on one wall of the carotid. So the moment I put the stent in, the next thing that happened was the whole thing blew up on my face. You can see that we were trying to strangulate the patient's neck in order to control the bleeding. But finally, we had to put a covered stent and rescue the situation. Look at that. Look at that tremendous blowout. And finally, covered stent in place. And then we went up to do this mechanical thrombectomy. Right. So finally, unfortunately, we have no technique. We always look at the percentage stenosis. You know, this is a very interesting statement. The healthiest part of the donut is the hole. Unfortunately, you have to eat through the rest of the donut to get there. And that is the problem with carotid plaques. Hopefully, you guys will help trying to define plaque imaging in a much better way. That's our team. So I'll stop there, take any questions, and I'm going to share something else. Aubrey, off to you.
So does anybody have any questions at all for Raghu? I think there's awkward silence, Raghu. Would you like to move to the next bit, Raghu?
Yes, I am going to move to the next bit. I have too many bits here. Yeah. Can you see this screen? Aubrey?
Yes, I can, yeah.
Let me know if you can see the video. So that's the carotid plaque. You can see the wire go past the plaque. And then...
No, it's not playing at the moment, Raghu, at the moment.
Is that right?
Not at the moment. I've got,
What can you see?
We can see carotid, bifurcation, and plaque.
You can't see the...
I can see there's a wire just off to the side of the screen.
You can't see the device filter deployment?
No.
Right, that's a flaw. I don't know how to rectify that flaw. Let's try it without... What can you see now?
Magged up.
No, can you just see the slide? I have tried to...
Oh, there's a play button on there now.
Yeah. Can you see it now?
Yeah, that's good.
Okay, so that's the wire going up of the filter device. That's the filter device being placed there. And then once the filter device is placed, what we are now going to do is pre-dilate. That's the pre-dilatation balloon that goes up, dilates the plaque a little bit. And then once that plaque gets dilated, you can see that microemboli are going up that are getting caught. Then you go in with the stent. The wall stent, you can recapture it. If you're not happy with the position, place it where you want to place it. Then put the stent in. Like I said, the stent is sized to the common carotid. As you can see, if you don't size it to the common carotid, it'll be flapping in breeze, cause more thrombotic, embolic episodes. Then you dilate it. Once you've dilated it, then you put the capture wire of the filter device and then capture the filter device out and then take the whole thing out. And that's the end of stent placement. So that is what you're doing. Filter device in the first pre-dilatation, stenting, post-dilatation. Okay, good. So what I'm going to do is to go to the next slide, if possible. And going to show you a little bit about the filter device. Can you see my filter device now?
Yes.
Aubrey?
Yeah.
So this is the filter device. I'm just going to show you how the filter device is prepped. So it needs to be like that to deploy it through. And the third blue thing is, so what we do is the kit also has an introducer. So both the capture and the filter device come up. The filter device is black in color at the tip, and the retrieval is white in color. It doesn't matter. You take that yellow bit out, and the filter comes exposed. So what you do is you take the filter out, and I'll show you in a bit. So you can see that there, what we're doing is dipping it into fluid and then capturing the device so that there are no air bubbles caught in the filter device. Once we capture it, then we can give that, pull it back to more than 1 millimeter into its parent sheath, then put it into that introducer, give it a bit of a shape, and then take it in through a hemostatic valve or a sheath or whatever it is. Okay. So I'm going to stop there, and then I think I've covered most of the things that you would need for a basic carotid stent situation. If there are any questions, I will take questions, or I will stop at this point, Aubrey, if that's okay.
That's great, Raghu. Thank you very much. Does so we've got a hand up there.
Jan,
Yeah.
go for it.
Yeah. Hi, Raghu. I'm Jan. I'm one of the INLs in Oxford. Thank you for your presentation. So I have a question. So is the MoMA device available in the UK, and has anyone had experience with using that?
Okay, so none of us have had experience. I don't know whether it's available in the UK. I cannot remember any of my colleagues saying that they've used it. Essentially, it's a reverse flow thing. The question what we're asking ourselves is, can you stop forward flow in the carotid when you're putting that stent in? So basically, whether you can suck back the blood and provide a situation where you can have a reverse flow. I don't think it's available. The interesting bit of it is that when you go and speak to people from up and down the country, none of us have had a major embolic event post carotid stenting. So that's what that device would probably help in. What we don't know is whether that'll help reduce microemboli to distal circulation and cognition or something like that. So I don't have any personal experience.
I see, because recently we had a case with a kind of floating thrombus type of picture in the ICA. So
Yes.
like after a long deliberation, well, we decided basically to do nothing. And I think if that was available, it would be very helpful. But equally, other balloon catheters that we use for stroke, like the flow gate, would probably do the job as well. Yeah, but thanks for your input. It's very helpful.
Are there any other questions at all? Okay. Well, thank you very much, Raghu. Thank you for giving your time this evening and presenting all those fantastic cases and giving us different techniques for doing this and doing the carotid stenting. So with that, I close the teaching session. Thank you again, Raghu. Thank you for everybody who's attended, and everybody have a good evening.
Pleasure. Thank you very much, Aubrey.
Okay, thanks. Thank you, everybody. Bye.